Hello and welcome. Today we're diving into the world of cardiac arrhythmias, specifically focusing on accelerated idioventricular rhythm, or AFR. It might sound complicated, but we'll break it down to understand what it is, why it happens, and how it's managed. So, what causes IVR? The primary culprits are often related to underlying heart conditions or certain situations that disrupt the heart's normal electrical activity. Acute myocardial infarction, or a heart attack, is a common trigger, especially during the reperfusion phase when blood flow is restored to the heart muscle. Other potential causes include digitalis toxicity, electrolyte imbalances like hypokalemia or hypercalcemia, and certain medications. Sometimes, AVR can occur in individuals with no identifiable underlying heart disease, which is considered idiopathic. To understand AIVR, we need to look at the heart's electrical system. Normally, the sinoatrial or SAE node is the heart's natural pacemaker, initiating the electrical impulses that coordinate heart contractions. However, when the SAE node's firing rate slows down or impulses are blocked, a backup pacemaker in the ventricles can take over. AVR occurs when this ventricular pacemaker starts firing at a rate faster than its usual escape rhythm, typically between 40 and 100 beats per minute, yet still slower than ventricular tachycardia. This accelerated rate can sometimes compromise cardiac output, although frequently it is hemodynamically stable. AIVR is most commonly observed in the setting of acute myocardial infarction. However, precise epidemiological data on AVR is limited, as it's often transient and self-limiting. It's estimated to occur in a significant percentage of patients during the reperfusion phase after thrombolytic therapy or percutaneous coronary intervention following a heart attack. Outside of this context, its prevalence is lower and associated with the other etiological factors we discussed. The signs and symptoms of IVR can vary. Many individuals with AIVR are asymptomatic, especially if the rhythm is short-lived and the heart rate is within the lower end of the range. However, some people may experience palpitations, a feeling of skipped heartbeats, lightheadedness, or even mild chest discomfort. In more severe cases, if cardiac output is significantly reduced, symptoms like shortness of breath or even syncope or fainting can occur. Diagnosing AIVR relies primarily on the electrocardiogram or ECG. The ECG will show a wide QRS complex indicating that the impulse is originating from the ventricles. The heart rate will be between 40 and 100 beats per minute. It's crucial to differentiate AIVR from more dangerous ventricular arrhythmias like ventricular tachycardia, which typically has a faster rate and can be life-threatening. A thorough clinical evaluation and assessment of the patient's medical history are also essential. While AVR isn't typically categorized into different types, it's important to distinguish between AVR occurring during acute myocardial infarction and AR that is associated with other underlying conditions or is idiopathic. The approach to management can differ depending on the underlying cause. In many cases, AVR is benign and doesn't require specific treatment, especially if the patient is asymptomatic and hemodynamically stable. However, if the rhythm is causing symptoms or compromising cardiac output, treatment may be necessary. Addressing the underlying cause is paramount, such as correcting electrolyte imbalances or discontinuing offending medications like digitalis. In symptomatic cases, atropine may be administered to increase the sinus rate and suppress the ventricular rhythm. Antiarrhythmic medications are generally avoided unless the AIVR degenerates into a more serious arrhythmia. Preventing AIVR largely focuses on managing underlying heart conditions and minimizing risk factors for heart disease. This includes maintaining a healthy lifestyle with regular exercise and a balanced diet, managing blood pressure and cholesterol levels, avoiding smoking, and carefully monitoring medications that can affect heart rhythm. Following medical advice and adhering to prescribed treatment plans for existing heart conditions are also essential. The prognosis for AVR is generally good, especially when it occurs in the setting of reperfusion after a heart attack. In these cases, it's often a transient and self-limiting phenomenon. However, the long-term outlook depends on the underlying cause and the presence of other cardiac conditions. Recent research has focused on identifying specific biomarkers that may predict the occurrence of AIVR after myocardial infarction and on developing strategies to optimize reperfusion therapy to minimize the risk of arrhythmias. Further studies are needed to fully understand the mechanisms underlying AIVR and to develop targeted therapies to improve patient outcomes. Thank you for joining me as we explored accelerated idioventricular rhythm.